Okay, let's go ahead and get started. I'm sure a few people will be joining us as we come in, but I will start sharing my screen. You probably saw, and if you could just give me a thumbs up or sign. Yep, good. Okay. You probably saw in the slideshow that was starting a little bit about myself, but I will start by just telling you that I'm a professor at UNC Charlotte. This is my third year here. I was actually a professor at the University of South Alabama for 20-some years before getting recruited to UNC Charlotte. I'm loving Charlotte as a city. The explosion of construction is quite something to behold. But I'm learning more about the different places and agencies and ways that we are serving our community. So as some of you know, I've asked you to put your name and where you work, where you're from, what you do in the chat, so that if we have a chance to meet each other in person, which I always hope for, we will have a little bit, I'll have name recognition and connection to you. I was invited to come and speak to you about motivational interviewing. And I'm very passionate about motivational interviewing. I actually teach our doctoral students in our clinical health psychology program, motivational interviewing as like a base first off intervention that can be added with or can be conjoined to cognitive behavioral therapy and a variety of other evidence-based practice, but it's generally really a good way to start with clients. And particularly, there's just some principles of motivational interviewing that I think help us work with a variety of different people who are coming in wanting to change some aspect of their health behavior, but have ambivalence about doing so. And the core feature of motivational interviewing is that we all have ambivalence about change. We both crave stability and for things to stay the same. And when that's not going very well, we also seek novelty and want things to be different. And those two forces are at play for many of us throughout our lives. So I'm just going to briefly show you the learning objectives for today's session, which hopefully you saw in your materials. But we're going to talk about the basic aspect of the human experience that routinely shows up in clinical settings, health settings, school settings, any place where the conversation might be around a topic of change. And these aspects of human experience support the necessity of using MI in many of our change conversations and our helping interactions. We're going to go through the stages of change model, which many of you are probably at least partially familiar with. And we're going to talk about how when we match our MI skills to our stage of change, our effectiveness is enhanced. We're going to describe and talk about how MI is not just a toolbox of tools, but it actually has a foundational spirit that these interventions spring from. And without that foundational spirit, they're considerably less effective. And that there are principles in which we enact MI. And we're going to talk about what that looks like and practice those. We're going to describe the basic skills. And then we're going to do a few practice experiences where we recognize, highlight, and elicit change talk from other people. So that's the goal. It's an ambitious goal. Often I do a full day workshop on MI. So we'll see how far we get, but we'll probably move along quickly. But know that practice, deliberate practice of these skills is actually essential for mastery. And there's pretty good evidence that 10,000 hours of deliberate practice is part of what moves people from beginning competence to expert utilization. And so that means lots and lots of practice outside of workshops in your daily life in a variety of different domains to get skilled with the tools and principles of MI. Okay, so I wanted to start us off with a working definition of what we're talking about. So when we talk about motivational interviewing, what are we really talking about? And if you go out to the literature, or if you purchased textbooks on MI, and I have probably about 7 or 8 different ones behind me in my office here at UNC Charlotte. You'll see that there are lots of ways to define what MI is. But I think this definition really captures what it is that we're talking about today, which is it's a collaborative partnership, exchanging conversational style. So it's a way of talking with other people where it's not expert to patient, but it's also not patient and we're just following them. It's a guiding interactional style that strengthens the other person's own motivation for and commitment to change. So our goal in the conversation is always to move back to what is it there that our patient or our client or the other person is wanting from the change. What is motivating them? How do they understand their own barriers to change? And what ways can they problem solve to move forward to get closer to living the life that they want to live and to enacting the behaviors that they value and that are closer to what they anticipate they would want to be doing in any given situation. Okay. So there's also, when you go to the literature, there's a number of people writing about what MI is not. And just as it's important to say what it is, I think it's also important to sort of go around and say what it is not. And the things that I want to highlight on this list is that it's not just Rogerian client-centered counseling, which is a lot of reflection, although reflection is one of the main MI skills. Actually, if you read the MI literature and get trained to MI, the way that MI therapists do reflection is a little different than how I was taught to be a clinical psychologist in graduate school. So I'm going to tell you a little bit about that when we get there. It's also actually not easy. And it's funny because every time I teach it, every time I practice it, I see ways to tweak, tighten, change. I see how I flip into telling people what to do sometimes, or just letting the conversation drift or chit chat, or different things can happen if you're not paying attention to it. So it's easier to do with lots of practice, but it actually requires intentional work. It's not just a tool. It's not just a way of tricking people into what you want them to do. And it's probably not really what you were already doing. Okay. So I don't know how this will go on our Zoom world, but I'm wondering if I could have a volunteer who's willing to unmute themselves. And everyone else, I would like you to play along at home. So I would like you and when we get our volunteer to think about something that you would really, really like to change. So something that you would like to change, but you haven't yet changed. And this doesn't have to be a really true thing, meaningful thing, important thing. But if it's real, it's a little more helpful. So even if it's something like, for me, I am consistently fighting with my desire to drink Diet Coke. So I am wanting to reduce my Diet Coke consumption. So can everyone just take a moment and think of one thing that they would like to change? And when you have that, if you just want to give a thumbs up, that would be great. You all know how to use your thumbs up by now on the keyboard. Yep, I see some thumbs coming up. Excellent. There's a thumb. Good. So just be thinking about that. There we go. Just be thinking about that one thing that you would like to change. And when you're choosing that thing that you want, but you haven't changed yet, and it's something like, like I said, you want to sleep better, you want to eat healthier, you want to exercise, you want to drink less coffee, you want to eat less sugar, you want to spend less time playing on your phone, you want to pay more attention to webinars, whatever it is. I want you to really lock down on that in your mind. And then I'd like for one of you, if you're willing to put in the chat what your thing is and unmute yourself, that would be great. Is there someone who's I'm looking to see if there's a hand up to see if anyone's willing to be the volunteer? Okay. Nyambi, would you be willing to be the volunteer? You'd like to increase your water consumption, right?
Mm-hmm. Yeah, I will.
Perfect. Okay. So I happen to be familiar with this a little bit because I have a kind of a chronic kidney condition. So literally every time I go to the doctor, they talk to me about increasing my water consumption. And so I'm going to tell you, Nyambi, why you need to make this change. So first of all, water is really, really good for you, and it's non-caloric, and it flushes out the toxins in your system. And so if you really want to be a healthy person, it's better to drink water. There's lots of ways you can do this. You can put an app on your phone. You could bring a water bottle to your workplace, and it's pretty easy to accomplish. So like next time I see you back in my doctor's office, I'd like you to tell me how much more water you've been drinking. Okay.
Okay.
Okay. This is not an atypical reaction when somebody goes to the doctor and they say, I need to increase my water, or the doctor tells you they need to increase their water, or when someone says you need to do your homework or any of your change. So I'm hoping you're all kind of playing along at home and imagining somebody telling you that. And my question to Nyambi is, what were your emotions when I was talking to you?
Just kind of like, I know that.
Yeah, right. Exactly. You don't think I know that already, LR? Right? Okay, good. What else?
I don't know. It just felt like listening. Like I wasn't necessarily engaged. It just felt informational and kind of like, right. I know that. That's why I need to do it. Right.
Yes. Okay, good. Well, what we know from, again, lots and lots of research studies is that, and what you keep telling me is that you just felt not heard. Like, I know that. And I heard inattentive and passive. Like, yeah,
right.
Be ready. So you weren't, luckily for me, you weren't too mad.
No.
Thank you for that. However, what we know is that if we come in and start telling people, essentially wagging our finger at them and telling people, you need to change, and this is why you need to change, and let me tell you all the reasons for changing, what it tends to do is push people into the one down position, which actually makes them to right themselves. They start arguing with you about how you don't get it. So if we the conversation go on, you might have, and a very common thing for people to do is to basically start telling me why it's a little harder to drink as much water. I'm acting like it's easy, right? And you then be telling me it's actually a little harder than you think, Dr. LR, and this is why I can't go to I teach at school and I can't go to the bathroom all the time. Whatever all those things are. So what's interesting, and I see Jacqueline sort of commenting here, is that the more we sort of give the advice and give the reasons and tell people why to change, it actually promotes people telling us why they can't change, which is the opposite of what we want. And it often makes our recipient of our advice or our, change also angry, ashamed, and not in partnership with us. So the normal advice giving that we do has almost the opposite effect of what we want. So thank you so much for Naomi for agreeing to be the participant. Good job in a webinar.
Thank you.
I really, so what we know is that if we take the stand of you must change, what the other person is going to do is kind of argue with us about why they shouldn't change, because the normal human response to the writing reflex is actually to take the other side. And that's because a very basic aspect of human experience is ambivalence. So people, even if they want to change, and you all playing along at home, we're thinking about something you really want to change. So even when your heart is set on changing, there's also a part of yourself that knows that change is difficult, that it's going to mean that you're going to spend more money or make more effort or not have that can of Diet Coke when you feel like it, or not be able to go with your friends in a certain way, or have to figure out how to do the bathroom, or whatever all those other things that change is going to bring in your life. That's kind of scary. And it turns out that people really both want and crave to do better and different, and also are afraid and somewhat, to a certain extent, intolerant of all that uncertainty. So I'm sure you've had multiple experiences of the writing reflex, where somebody tells you they want to get a divorce or leave their partner, and then you start saying yes. When I was in my 20s, I actually had a very close friend who had gotten involved with a married man, and she came to me and she said, I'm involved with this married man and I want to break it off and leave him. And I said, oh yeah, here's all the reasons why you should do that. He's never going to leave his wife, blah, blah, blah. I just laid out the whole thing for her. And then she basically said to me, I can't leave him. And she didn't leave him for like 4 more years, and our friendship suffered, as well as me not helping her in any way, except to maybe have her think about all the reasons she didn't want to change. So what we know is that there's some basic fundamental concepts about readiness and change that have been very, very well supported in the research literature. So I'm going to summarize these to you. And I think once we accept these as sort of pretty well established principles or truths, it actually reduces our likelihood of getting frustrated and burnout. So not only does it help the people we're interacting with make more change, but it actually helps us. Because it's pretty frustrating to keep telling somebody to drink more water and then they don't. And you're broken record. You're like, I don't get it. There's every reason why they should drink water. There's every reason why they should be doing this, right? They should lose this weight. Many of us are in these relationships, even with our closest people, our spouses, our children, where we keep telling them why they should do different, and then they don't. And in fact, they argue with us about why they're just fine the way they are. And it's not good on either side of this equation, right? So what are the basic concepts about readiness to change and change that are sort of at the heart of, or foundational to, the motivational interview? So the first thing is that ambivalence about change is normal, and that it occurs throughout the change process. So even once people start to make a change, it doesn't mean that the ambivalence goes away, right? And so if you can just accept, and in fact, MI, as it has evolved and new editions have come out from Miller and Rohling, they've moved away from the idea of resolving the ambivalence to accepting it. To accepting that ambivalence about change is just going to appear and appear and appear. So it's a both and situation. It's both true that people want to change and that they struggle with change. And that both and idea means that we don't have to have people solve their ambivalence before they start a change process. And we don't even have to have them solve their ambivalence at the end of the change process. They can still miss that cigarette. They can still miss parts of things that they used to do, and stay with the change process, right? We can accept that ambivalence can exist. The second fundamental principle is that change is nonlinear. So what we know from just all kinds of change processes, so studying people quitting smoking, quitting drinking, drinking more water, starting exercise programs, flossing their teeth, like any sort of change process, is that there are initial steps, there are setbacks, and sometimes there's a return to old behaviors before the change gets more solidified and stable. And with some things, the possibility of a return to use really is always there. There's some small possibility of return to use even years after the change has happened. So for example, with alcoholism, the possibility of return to use still remains fairly substantial even years after the person has made the change or decided to quit drinking. So under certain conditions, with certain stressors, in certain temptation, with certain lack of support, a return to use can happen even 10 to 15 years out after stopping of drinking or smoking. And so we no longer call it a relapse, we actually call it a return to use, because then we can look at the decisional process made to return to use, and then we can remake the decision to return to abstinence from a position of less shame and blame. The second part of change being nonlinear is that many, if not most people, clients, will have attempted to change before talking to us about it, whoever we are, whether we're a school counselor, a behavioral health provider, a clinical psychologist, a teacher. Most people actually try to do stuff on their own first. And they do that with either more or less success. And it turns out that understanding what they've already done is important. And I don't know if Naomi experienced this in our really brief interaction, but if I had sort of told her, you need to bring a water bottle to work, you need to use one of those apps on your phone that says drink more water, there's a high likelihood that she already tried one of those things. Naomi, did you try one of those things?
In real life?
Yeah, in real life.
No, not necessarily.
Not yet. Okay.
Not yet.
So if I had listed a whole bunch of different things that you had done to try to increase your water intake, the odds would be that you already have tried a few of those things. And by me not actually having you tell me about what you've already tried, I just increase your resistance to my efforts, because what will stick in your mind cognitively is that the one thing that I said that you're already doing, and your brain, because we're ambivalent people and resistance actually is part of how we operate, your brain will actually stick on that little point and go, wow, that's not going to work. I've already done that. And so your next conversation with me is likely to be, I already tried that. And this is what I tried, right? So if we start with the principle that many, if not most of our clients have already attempted to change without our help, and we understand that, and that they have had some successes and they've also had some return to use, or they wouldn't be struggling with it, then we can start the conversation there and again, bring them into the partnership, right? The third really big piece, so ambivalence is normal, occurs all the way through, change is nonlinear. The third piece is that readiness to change, our readiness to change is not static. It's not a set thing. It's actually not a part of our personality. It's a fluid dynamic. So psychologists were guilty of this. And I have almost everyone in my family is a teacher. I have a daughter who's a teacher in the Charlotte-Mecklenburg public school system. And sometimes it's very challenging to not say that kid's got a problem with their personality. They're just a resistant kid. They just won't do anything that I tell them to do. And we make readiness to change characterological. However, MI is built on the thought that actually our ability to kind of handle one of our problems and make change is a lot more fluid. And we, as people in the helper role, can influence other people's readiness by what we say and do. And we can influence people to get more ready to change. And we can actually influence people to be less ready too. And so MI is about what do we know from the research evidence that we can do as helpers to actually help move people towards being more ready to change a problem behavior. So what we know, again, is that effective clinicians, effective helpers attend to readiness in their work. And one of the ways they do this is by using scaling questions. And scaling questions are a way to ask other people, clients, about the importance of making the change, their readiness to make the change, and their confidence of making the change. So I'm going to show you what these scaling questions look like. So scaling questions are funny one item, very brief ways to have a conversation with someone that can be used in a public health setting. It can be used in a school setting that sort of says, hey, Joshua, on a scale of 1 to 10, people have been telling you that you need to do your homework, and you've been saying, yeah, I got to do more homework. How important is making that change where you're going to be doing more homework? How important is that change to you? With 0 or 1 being that doing more homework, making that change to do more homework right now is just really not important to me. There's so many other things I care about. And 10 being, it's really the most important thing. I'm just completely focused on it right now, right? And you can ask that for how important the change is. You can ask people how ready they are to make their change. And you can ask them how confident they are in making this change. And what's so interesting is that it doesn't matter what their response is. There's no right answer to where you're supposed to be in 1 to 10, but any answer gives you information and also gives you a really nice follow-up question with clients you're working with. So the follow-up questions are, so let's just take a 5 as their answer. So we talked to our patient, they want to increase their water intake. And I said, so on a scale of 1 to 10, how important is it for you to increase your water intake right now? And the patient says to us, well, it's a 5. With 1 being not at all and 10 being something. And I say, okay, you chose a 5. So tell me a little bit more about why you chose a 5 and not a 2. Like, what pushed you up to a 5 from like a 1 or 2? So if the patient now starts telling me what pushed them up to a 5, they're going to be telling them they're going to be eliciting for themselves all the reasons why it's more important to make the change now. So no longer am I telling them why they should make the change. They're now telling me what got them to a 2 to a 5. And their answers are really important because they're tailored to their own situation. They're not me guessing. They're not what I think should be the right answer. They're literally what's important to them. So they're going to say, well, I'm a 5, not a 2, because I care about my kidneys, because I get a lot of acne when I eat too much chocolate, and water helps my acne go away. I'm a 5 because I feel more relaxed when I go to the water fountain every, once an hour and take a break. I want to drink more water because I'm spending way too much money at Rhino Market on expensive drinks. Who knows what they're going to tell us? But the things that they tell us are the things that actually are reasons for them to consider the change important, to be ready to make the change, and why they feel confident. And that's really important. Conversely, with the scaling question, you can flip it and your follow-up question can be the opposite. So if you've said on a scale of 1 to 10, how confident are you in making this change? And they say a 5, you can also ask the question, okay, you're saying a 5 and not a 9 or a 10. right? So you're telling me you're medium ready to make this change. What pushed you down to a 5? What made you a 5 rather than be up at a 9 or 10? And what you're going to get there is all the barriers to change. They're going to say, well, I'm not really ready because blah, because I don't have time to go to the bathroom. I really like going to Rhino Market. They know my name there. They have this specialty drink that I really look forward to. Who knows? Like, clients say all kinds of stuff. Sometimes they say things like, my husband spends a lot of money on golf, or he bought a new car without asking me, or crazy stuff. And you're like, and so I'm going to keep my specialty Starbucks coffee. We had clients say that just recently to us. It's like, I don't want to give that up because that's the one treat that I have, right? So that pushed me down from a 9 to a 5. That is really important, because then you'll start thinking to yourself, okay, if that treating is important, what are other treats that maybe don't have the same negative health effects as doing this, right? Then you can start addressing, thinking about how to work with them on the barriers. So those two questions. So one of the first ways to sort of get in the MI kind of mindset is to be thinking about, how do I ask an open-ended question that gets my person I'm talking to explain to me what their reasons are for change, explain their motivation to change in ways that really articulates their motivations and also articulates the barriers. And the scaling questions do just that. The other thing, so you may have already seen these, those of you who've, have read some about motivation to change or MI, have gone to some workshops, you probably have already seen that MI often comes with a ruler. And the ruler is something that clinicians and school counselors can have sort of laminated, and you can literally pull out your ruler and say, how ready are you right now, how ready are you to change? And you give them the ruler and say, point out where you are in the ruler, right? What's really nice about MI now, and as it's come to, from childhood through adolescence to emerging adulthood, is that MI now has been working on tailoring what to do with patients that are different levels of the readiness ruler scale. So not only does asking the scaling question help you get an understanding of what, and help the patient articulate, instead of resisting you, figuring out why they want to change and what their barriers are, but it also allows you to tailor the interventions. And we're going to talk about that in just a second. Okay. So bottom line is, so the do of this is the scaling questions are really important things to do. The don'ts are, which we've already talked about, but the fifth one, I call these the big 4 and the sleeper. And the sleeper is one that we in certain professional roles do an awful lot of, and it's actually counterproductive. So we know that we shouldn't really try to convince clients that they have a problem. We know that if we argue for the benefits of change, they're going to argue why they can't. We don't tell them how to change. Scared straight has been shown not to be effective in study after study after study. So warning clients about the consequences of not changing, threatening them. What's interesting is, again, the way our brains are designed is that just sets people up to give you all the examples. Like, sure, smoking kills people, but I have 3 people in my family that have been smoking their whole life and they aren't dead. So they'll bring up the counter example, because that's the writing reflex. That's what people do. The sleeper is that we are often lulled into doing a similar thing with advice. We believe that if clients just knew this one piece of information, then they would see and it would all go well. If they just knew that about this particular app, or had this water bottle, or if they just knew about a scheduler or a planner, if they knew to make a to-do list, then they wouldn't have ADHD. Like, we just want to give that one piece of advice. And yet all of these things actually bring resistance. And so we need to figure out what to do instead. Okay. So basically, we're now seeing that motivational interviewing, we know if we're over here on the directing side. So if you think about the conversation is taking place in a car, and I love the guy who does karaoke in his car with people. So if you're in a car, right, and you're with your person in the car, if you're driving the car and fastening their seatbelt in and sort of telling them where you're going, you're going to get a lot of resistance, either passively or actively. So in our example at the start of our workshop, we got a lot of passive resistance. She just doesn't know. It's harder than she thinks. I'm not really mad, but I'm sort of checked out, right? Other people will give you really active resistance. So directing brings up that writing reframe. Following the client does a lot, and there's very good studies that show that if you are really client-centered and you listen and support and affirm, that lots and lots of people have not ever really experienced being heard. And so we really do want to be able to follow a following style, and that's helpful in a lot of situations. The thing about a following style is that the evidence suggests that it doesn't help people with behavior change as much. So if the issue that we're working with is something where some behavior has to change, the guiding style of motivational interviewing has the most success. And so MI really is, kind of in that car, and you've got the other person is driving now, you're not driving, but you're sitting next to them sort of teeing up. Maybe you've got the Google map on your phone and you're sort of teeing up. It looks like maybe we're supposed to be going right in the next step. What do you think about that? Can you get over there? Is that going to work? Like you're working together to get where you want to go. Okay. So that's the setup for this. When you think about MI, and I am going to just kind of show you the big picture of MI and what it looks like in this amazing slide that I have here. What it's about actually is, like I said, seems easy, but it's harder than you think, requires some practice, but we're going to go through this basic model today on a more quick level with some practice to get you the sense of, so what does this whole thing look like? So the start is with the spirit of MI, which is, and the spirit of MI, actually the acronym that works best to remember it, I think, is PACE. So we'll talk about what that looks like, but that's sort of the underlying foundational. The principles include empathic listening, amplifying the ambivalence. So instead of thinking it doesn't happen, when you get resistance, your job is not to fight it, but to roll with it and to actually listen and support the resistance. So you kind of come from behind. And then listening for strengths and supporting self-efficacy as important parts of the change. The actual skills of MI are known as the ORs, and now people call them ORs plus I. So open-ended questions, affirmations, reflections, and summaries. And then the very important part is, but what are you reflecting? What are you summarizing? What are you questioning about? And the acronym for this is called DARN CAT. So you're listening for change and commitment talk. And so we're going to look at what that is. And it's in that package of having the spirit, using these principles, having the ORs, and applying them to change talk and commitment talk, the behavior change is the most likely to occur. Okay, so this all comes, MI is not the same thing as, but it really comes from Prochaska and DiClemente's stages of change model, which basically is, again, a conceptual model, but it's been well supported empirically, that people have a certain process of going through when they're trying to change a problem behavior. And the process really goes from what we call pre-contemplation, and with some adolescents and certain types of clients, I prefer to call it anti-contemplation, but pre-contemplation to contemplation to preparation to action to maintenance. So I'm going to give you just a quick example of the kinds of things that you might see in these different stages. So what does this look like? So pre-contemplation is really the stage of change where the person has really not thought about it too much. Like, it hasn't even occurred to me that I want to drink less or smoke less, or, I'm fine with my marijuana use, or, my water intake seems good. And they may or they may not actually know the health risks involved. But this behavior change is usually something that's being asked for by somebody else. So this is common with adolescent clients and working with adolescents. It's common with substance abuse patients. It's not uncommon in marital situations that one person is saying this has to change and the other person's like unaware or not really even thinking of that behavior change. So there's lots and lots of conversations where the one person might be in a pre-contemplation mode. Contemplation is really where the person is kind of thinking about it. They've become aware of some health risks, but they're really just sort of weighing their options. They're kind of thinking about, maybe I could do this, maybe not, I'm not sure. Preparation is, I've decided to change and I've made some plans to take action. I haven't taken the action yet, but I'm making some plans. Action stage is they've started to make changes, but the changes really might not be stable. And then maintenance is that they've made sustainable changes in the health behavior. So this was really the stages of change. This model was really fleshed out first with regard to substance use disorders. And so, pre-contemplation was really, I have no reason to stop drinking or cut down my use. Contemplation is like, wow, I'm getting too old for this. I can't stay up all night partying the way I used to or drink this much and still function, would be a contemplation action. Preparation is like, I plan to go to an AA meeting. Like, it's in my heart that I want to do that. Action is actually going to a meeting, for example. And then maintenance would be, I've just had my 3rd anniversary of sobriety. So as with any sort of stage model, it's, they don't capture behavior all that well, because as we talked about before, change is really not linear. So people have tried to model these behaviors on a circle. But for our brains to kind of get it, sometimes it is helpful to put them in a linear way. And what we know is from the MI work is that there often is a mismatch between the helper and the helpee. And the mismatch can be that often when people come into therapy, and I use this example because I teach graduate students who are therapists, and when they come in, the therapist often has the assumption, well, they've come in, so they must be taking action, they're ready to change, right? So the helper viewpoint is this one, that they're really ready to change, but the client's viewpoint may actually be more like, wow, I've gone from pre-contemplation to contemplation. I'm thinking about it, and I'm just kind of becoming aware of this. And though that separation between where the client is and where the helper is, that mismatch is what we used to call resistance, and now we call discord. That's the discord, right? And so the helper is pushing the client to move along this link as fast as possible. But because there's a mismatch, it actually promotes the client's resistance. Okay, We also have good research studies that have looked at the probability of behavior change with regard to the helper's behavior. And if the helper does what I modeled at the beginning, which, just to be completely clear, is not MI. So if the helper talks about why the change is important and the client nods the head, and you might remember that Naomi at the end was like, okay, so her response to my long thing about why she should change was okay. And I didn't get to see her, but she probably nodded her head. The probability of change after that kind of interaction is relatively low. And so if we want to increase the probability of change, we actually have to do different behaviors to get the client to do different behaviors. Because if the client thinks about why change is personally important to them in the scaling of questions, the probability goes up. If the client talks aloud about why the change is personally important to them, the probability of them making a change after session goes up again. If the client actually makes a verbal commitment to change their behavior that's directed from themselves, that's the highest probability of behavior change post-session from a research statistical standpoint, right? So this is what we're aiming for. Okay, so what MI has done is take the scaling questions and sort of said, hey, can we match what we're supposed to do based on where the client is? And if we can look at the scaling questions and sort our clients a little bit into groups. So if they're between a 0 and a 3 on the readiness ruler, they're really not ready. They're in pre-contemplation or very early contemplation. What should we do in that case? If they're somewhere between 4 and 7, they're in the contemplation stage. And if they're an 8 to 10, if they're on the readiness ruler somewhere between 8 and 10, they are actually ready to make the change. And the stage of change would be preparation or action. Okay, so we're using that readiness ruler and our scaling question now to try to figure out what stage of change they are. And then we're matching the stage of change with actual skills and interventions in session. So let's go through this a little bit. This slide's a little bit, circly, and it's circly because change is not linear. And so we're actually trying to model, we can model using math, but we're also modeling using diagrams to kind of show ourselves how these things happen. But if we go to the top of this and we look at pre-contemplation, the two behaviors that the therapist wants to engage in, and really the only two behaviors in, if the client's really in that 0 to 3 category, is empathy. So the helper should just be doing everything possible to understand what's going on for the client. And it actually looks a little amazing when the client is telling you things like they feel comfortable with their current heroin use. And you're empathizing with that and trying to understand it. So the heroin's helping you in this way, and it's your friend group, and it's numbing you out in this way, and you're getting this, and you're fully trying to really understand. And I can see why you're making this choice right now, and I'm getting how this makes sense to you. And it's from that position that, interestingly enough, at the end of a session or two like that, the client often says, well, actually, it's not all great. Here's the problems with using heroin. And then they take the other side. If you take the other side, you're going to be, again, in a problem of resistance. So finding out that they're 0 to 3 is really important. If they're in more that 4 to 7 range, what the activities look like from the helper side is that you're really exploring and amplifying the ambivalence, which means that a lot of the reflecting you're doing is not simple reflections of where they are, but more two-sided or complex reflections where you're saying, so part of you wants this and the other part of you wants that, right? And so you're capturing the ambivalence and you're actually making it more explicit, and you're getting as much on the pro side and as much of the con side for changing. And you're also doing the same for staying the same. So the reasons for staying the same and the reasons, not to stay the same, and the reasons for change and the reasons not to change. And those four things, four boxes, might have really different information in. They might have some of the same information, but they also might have different information. So it's only if they're in the 8, 9, 10 that you think about them as being in the preparation or the action stage, right? And if they're in preparation, a lot of what you're doing in the helping role then is making a good plan. And, probably many of you in the room know about SMART goals and how do you make goals that are specific and measurable and actionable and reasonable and timely. So there are plans that are probably going to make it, and there are plans that have some significant gaps and holes in it. And so, figuring out and getting the skills around making a good plan is part of what the work looks like in the helper role if someone's in the preparation stage. And then basically in the action stage, there's two things happening. One is that the helper role is to listen to the implementation of the plan. What about it worked well? Where did the plan actually fall apart? What were the stresses on the plan and the strains on the plan? Following up to where the plan wasn't as hardy or foolproof as we thought it was going to be, and or if the plan actually didn't work and there was some return to use or relapse, how do we cope with that and move back to preparation so that the relapse doesn't lead us back to pre-contemplation or contemplation, but the relapse moves us back to preparation again, negotiating a different plan. Okay. So I think the part where helpers get the most frustrated and burned out is when people come in. So it feels like they must be in this stage, they must be somewhere contemplating, and there's ambivalence there. So they must be more like a 4, 5, 6, 7, right? But then when they start talking to us, we realize, and they express to us that they're actually really in a 0, 1, 2, 3 on the readiness ruler, and they're really more in pre-contemplation. When that can happen might be because they've been referred to us due to non-compliance with something, right? So they've already not doing what somebody else has told them to do. So in the behavioral health world, we often get these referrals to behavioral health from doctors who are like, this patient just won't do what they're supposed to do. And I've told them to take their medicine and they're not. Or people sometimes stop taking their antidepressants because they have side effects that include sexual dysfunction, and they're not compliant, and yet their depression is getting worse and they're suicidal, and the doctor wants them to take this medicine, right? So we may get them as helpers when they're in non-compliance with another authority figure. They are often seen as argumentative, hopeless, or denial. They may even seem like they're anti-change. And it just really pulls from us the urge to try to convince them. And the key to not convince them is to express lots of empathy. So I make that point a few different times in the slides, and that's because it's actually this is the part where it seems easy, it's easy to say, and it's hard to do. And the way that it gets easier to do is to remember and practice the underlying spirit of motivational interviewing, which is really the pace, right? So what is this underlying spirit, and how do I just keep, taking that on and making that spirit part of who I am and how I work clinically with other people or help other people. And so if you look at the PACE Foundation, right, these are the 4 components too. So first is partnership, right? And the way that MI understands partnership is that you and the other person are in this change process as a team. And they are the expert in their life, right? And they need to be a very active partner in the change process, not a passive recipient, not just a, okay, yeah, I'll do it. So the partnership, through our scaling questions, we actively elicit the client's aspirations and goals, and we create a positive environment in which change is possible. There's a whole body of research in the therapy world that's around what we call common factors. So regardless of whatever theoretical orientation you take, whether it's psychodynamic or cognitive behavioral or schema therapy or acceptance and commitment therapy, what are the things that are common across how effective therapists in any of those theoretical orientations work? And one of the things that effective helpers do is they generate hope, right? So if we think about the partnership, where we know that they're the expert, that we support their self-efficacy, and we sit in that position that change is possible if it's meaningful. Acceptance is a really, really big one, and I could do an hour and a half, 90 minutes on just what acceptance really looks like, but Miller and Rohling have broken out acceptance into 4 pieces. These map on very nicely to Carl Rogers and client-centered therapy, that that we're sitting in a place where our people who are coming to us have absolute worth. They're not bad kids, they're not bad people, they're not impossible to change, they're not a write-off. Each person has value and potential. We have to really support that they have a choice, right? We can influence, but they get to choose and make decisions for their life. And then the real key here, particularly for people who come in and sort of pre-contemplation, is that accurate empathy. We have to have the desire and the ability to really see the world through their eyes. And so a lot of our questions are coming from an accepting stance of curiosity, like, help me see the world the way you're seeing it, because when I can see it through your eyes, I'm going to get why you're making the choices you're making, and I'm going to be able to support you in the change process, right? While we're doing that, we're also looking for ways to identify strengths and resources. It's very compassionate. And then finally, it's actually evocative. So the part that makes it less, moves it from that following over into guiding, is that we actually are asking and doing things that are eliciting the patient's own reasons for change and their own decision-making processes. And we're drawing out their ideas and solutions. They're the expert. Okay, so for a little break, we're going to now look at 3 examples, quick examples. And for our quick examples, I'm going to ask you to either give a thumbs up or a thumbs down. So thumbs up means it is meets the spirit of MI. So it's got a pace in it. It's partnering, it's accepting, it's compassionate, it's evoking, or it's a thumbs down. So here's our first example 1. So here's our person comes in and says, hey, I need to come up with some sort of plan to help me get back on track now. This health crisis has really thrown me for a loop. I just can't think about anything else. What do you think I should do? And the practitioner says, well, I have some ideas about what might help, but first let me hear what you've already considered. Thumbs up or thumbs down? Look at my people over here. Figure out. See a thumbs up from Terry. Okay, Terry, why is this a thumbs up, do you think?
Well, she had some ideas to give her, but she asked her first, let me see what you've thought about, what you've considered. So that's why.
Exactly. Okay, so this is a thumbs up because the client has asked for help. What do you think I should do? Which normally pulls us, those of us who are helpers, into the expert role, and we start telling them what we think they should do. But our practitioner here was savvy and said, hey, I do have some things that might be helpful, but let me first hear what you've already done and what you've already thought about. So they're now acknowledging that the patient is an expert in their own life. They're seeking collaboration, and they're looking at, the usefulness of prior change attempts, right? So good job, practitioner. Exactly. Good job, Terry. Okay, here's another example. So now we have Arthur, and Arthur is our client, and he says, I'm not going to keep that stupid thought journal. How does it help me to monitor all my loser thinking? I'm coming here to feel better, and paying attention to all my negative thought just makes me feel worse. And then our clinician says, okay, Arthur, you might be right. This works for many folks, but not for everyone. Maybe we need to try a different way to approach this. We've talked about other ways.
Language for us being.
What makes sense for you to practice instead? Okay, so thumbs up, thumbs down. Making you guys click around a little. Thumbs up, thumbs down. Am I spirit or not? Okay, I see Terry giving me another thumbs up. All right, so yes, another thumbs up, right? What we know is that even the best treatments won't work if the client doesn't implement them. And if we said, well, evidence says this really works and just do it, you need to do this because this is what happens, we're going to get into a power struggle. What do we know for the front? We know that power struggles always end up with the client losing their motivation for change, but us losing too, because then we get really burned out and dissatisfied and we feel ineffective, and none of us really wants to feel ineffective. So the worst part of the power struggle actually is that it leads to clinicians wanting to quit and helpers wanting to quit, because helping people who don't want to be helped, and that's how it ends up feeling if you're in a power struggle, just gets really tired, right? So nice thing about this is it's like, hey, there's no one way to, slice cheese. And so this avoids the power struggle and looks for ways to collaborate. Nicely done. Okay, so last one, we'll do one more. Tanya, they told me I have to have this surgery right away, but I don't trust them, so I haven't scheduled it yet. The practitioner says, why take the chance? They're the experts after all. Let's call from this phone right now. Maybe you can get in this week. Okay, is that in the PACE MI spirit or not? Thumbs up, thumbs down. See what y'all think. Give me a second to vote. Okay, so this is a thumbs down, and it's a thumbs down. Why? Because it's a missed opportunity to support the client's autonomy. The client is making a choice, and they're making a choice around a decision, right? And if you push hard, you're likely to get the client to basically say to you, yes, but, right? My teacher told me I have to do this, but I don't really believe them, so I'm not doing it, right? And if you say, hey, your teacher is the expert, you need to, let's do this right away. I'm going to sit you down here and make this happen. That does not support the patient's autonomy or the student's autonomy. It also really is likely to have you be doing what everyone else in their life's doing. And if you do the same thing, you can expect to get the same results, which have not been good, right? Okay, yep, thumbs down. Good job. Okay, so that's the pace, right? So what are the principles? Well, as you saw in the slide of sort of how it all flows out, the principles are empathic listening. You're really trying to engage. You're rolling with resistance. So if it feels like they've asked the question in a way that you're about to take the other side and to fight it, that's when you kind of, instead of leaning forward and kind of going for it, you lean back and say, hey, you're probably right. You know, that might not be helpful to you, you know, or yeah, I have some ideas, but I really want to hear what you're thinking, and you're asking permission. Okay, so you're not getting in that argument. You're amplifying their ambivalence. So you really get it. You're really getting both why they want this and also what they're worried about, what the barriers are, right? Okay, so, you know, really want to do these activities. So that first part, that empathic listening, is that we really want to have a non-judgmental attitude. And so if we come at it thinking that we're hiding the fact that we think they should change, and we have a sort of a secret agenda, and we're just trying to get them to do what we've told them to do, the odds of them changing goes down, because the thing that's louder than our words is our nonverbals. So if our nonverbal, like should, is out there and our verbal is trying to be accepting, there'll be a discord there in us, and the people working with us will say, I believe what her body language is telling me, and she actually thinks I should be doing this. So we have to work on our own non-judgmental attitudes so that we really can come to a place where we get it, that we have to kind of just figure out where our patients are at. We have to, you can't work from a place you're not there, right? So our goal always has to be curious and elaborate, like, you know, what does this mean for you? How does this work? How did you get to this being a good decision? That makes sense to me. How this would be, and it sounds like you weighed this and this, and like really trying to get what it is that they're trying to tell you. And that involves a lot of reflection. So there's a pretty good literature around the kinds of things that we do that actually breaks us away or moves us away from engagement, and things that move us towards engagement, and the kinds of questions. So if we get too focused on gathering information, or too focused on getting the solution right and giving them the information, if we lock down quickly on something without really understanding all the context, if we just try to diagnose, well, here's what's wrong with them, or if we stay at this very surface level, all those things are less engaging than trying to really ask the question about what does this person need and want from this encounter? How important is this problem? How does working together in this way generate hope and increase their autonomy and their agency in this situation? And what are their expectations for working together? And how can we kind of tell them about this encounter in ways that promote safety and elicits permission? So it turns out the ways that we really do that is probably the core skills of MI. And these skills are things that I would be so surprised if, you know, you didn't already know. So the question is not knowing them, of course. The question is how we use them, and how do we really like navigate around the water of behavior change with our oars. And our oars include open-ended questions So when we're pressed for time, we often move to kind of close-ended questions. And we say things like, do you know how bad that is for you? Right? And then the kid's like, yeah, I know. As opposed to, using keywords, and the keywords is, for open-ended questions are really how and what and why. Why is the most dangerous of the three, and that's because a lot of why questions can be perceived as judgmental. So if you're going to use a why question, it has to really come from a place of curiosity and be used strongly with pace. Otherwise, you're better off to stick with what and how. What all happened to you today is better than, did you have a good day at school? Yep. Right. Okay. Obviously, those of you who work in the school system or with adolescents know that adolescents are very skillful at taking open-ended questions and making them close-ended. So how did your day go? Fine. So you have to be pretty good at thinking of ways to generate open-ended questions in the context of people that are closed off. And a lot of that comes with greater safety, trust, and transparency. So really kind of taking those pace spirit and using them with a trauma-informed kind of understanding works. Okay, we have just a little bit of time left. Let me look at my time clock. We have about 20 minutes left, and I want to talk a little bit about how you use open-ended questions and the ORs, so affirmations, reflections, and summaries, to really evoke change talk. And so I'm going to give you some examples about, again, like, if they're talking about change, but they've expressed a lot of ambivalence, you can say, well, what part of this do you think you might be able to change? Or is there any part of what's going on, or any place in the day where you think a change is possible? What would that look like? How confident are you that you could do this thing if you made up your mind to do so? Why would you want to do this? What could be some advantages? What would be the reasons? Why do you think this thing has to change? So the open-ended questions can be targeted to really get at change talk, right? And these open-ended questions really allow patients to express their own views while you're following and understanding the patient perspective. So, it's especially important when you're looking at barriers. So an example here is, what negative consequences have you experienced as a result of your drinking, as opposed to, have you experienced negative consequences, right? What negative consequences have you experienced? They're going to actually have to think about the ambivalence and tell you a little bit of the other things, right? Okay. Affirmations. This is also a tricky part of the ORs. You don't want to engage in toxic positivity. However, you do want to actively listen for patients' strengths. You need to really look for their values, because one of the things that motivates people to change is if there's a discrepancy between their real self and their ideal self. People are motivated to move closer to their ideal self on the whole. Not everybody, some psychopaths, no, but generally people want to be closer to their values. And so you want to listen for those values, for those aspirations. You also really want to, while you're affirming strengths, you want to support autonomy, that they have choice and voice, right? You were able to lose weight before because of your perseverance and determination. Those strengths can also help you quit smoking. as opposed to realistically, it's going to be hard for you to quit smoking. And you think that that's helpful and it might be realistic, but that's not particularly affirming and hope generating, right? And that pace is really important. Okay, so I'm going to say, as we move towards the last bit of what we're doing here, the last 15 minutes, that when you're in the car, right, and now you have the client driving and you're sitting next and you have a pace, the car's going at a certain pace, right? So your partnership, you're affirming, you have compassion, you're evoking things. What you're driving towards, what you're listening for is really change talk, okay? And the recognition of change talk is really unique to motivational interviewing. It's intentional, and there are specific skills in evoking change talk, like through the scaling questions, and that your job is to really reinforce that change talk. So what is change talk? Change talk is any client speech that favors movement toward a particular change goal, right? So we have to listen for and tune into anything that the person is telling us that implies that they're actually moving towards the goal that they've told us about. And we're going to highlight that to them, right? And the way we're highlighting that to them is by reflecting it back, okay? So change talk, and I'm just going to show you this picture. For those of you who love cats like I do, the darn cat, right? So we have a pace about us in the car. We've got our oars. So maybe we're not in a car, we're in a boat, we're in a motorboat. We've got our oars, right? So we have our open-ended questions, our affirmations, our reflections, and our summary statements. And what are we looking for in our boat with our oars? We're actually got our binoculars out and we're looking for our darn cat, because we're listening for and looking for change talk. And darn cat is our acronym for change talk. So what is change talk? Change talk is the kind of change talk is what's reflected in darn cat, right? And I think what's really ends up being most helpful for helpers is to hear what that would look like in words. How do we get that reflected in language? So if I have a preference for something, I desire something, the words you're going to hear is I want to, I wish I were more, I would like to, I hope to, the kind of the wishing, wanting preference is my goal. It's my value. It's what I'm hoping for. So those are really important things, because that's the motivation for change, right? I would like to be closer to my grandkids. I would like to be alive when my daughter gets married. I want to. Those are the reasons why the patient might want to stick with a behavior change goal. Ability is the A of darn cat, which are things like I could, might. In the deep South in Alabama, we say I might could be able to do that. So these are things where I'm thinking I could maybe do that, right? So those are places to support self-efficacy. Obviously reasons, so any reasons they're giving you, I'd feel better if I did this, I would have more energy, I don't want to go back to the hospital, I want to have this thing in my life. So reasons are any specific arguments. You definitely want to keep track of all those, and you want to keep track of those in the patient's own words, because you want to use their language. These are their reasons, they're tailored to them, they're personal. You want to hold on to those best as you can. Needs, these are like shoulds, ought to, and a lot of times as therapists, we're told that should statements are bad, but should statements are also reasons to change. I really should, I ought to, So there's a part of you that's sort of a conscience that's telling you that you should do this, that you're ready to do this, you're feeling obligated. So there's a need there, right? Commitment. So the darn of darn cat is like over on the pre-contemplation, contemplation start part of the stages of change. And so language you would hear that will let you know the person's in pre-contemplation, contemplation is that they're expressing darn, desire, ability, reasons, and need. If they're really talking about the cat of darn cat, they're over in the preparation and action stage. So things you would hear over there is commitment. So I'm going to, I will, I intend to. You hear those statements. You definitely want to affirm that, support that, reflect that back, summarize. It should be a part of your summary statement, and then activating, taking steps. So if client comes back, I actually went out and this week I started yesterday. I didn't do that. They are in the action stage. And again, you want to talk about those choices, affirm their autonomy, and their look for the strengths that they had in and what they did to be able to make those actions and make those changes. So that's really the darn cat, right? And as I said, the darn is the preparatory change part. So if you're hearing desire, ability, reasons, and need, the darn, these are things that are telling you that the patient is leaning and leading in the direction of change, but by themselves, they're not really there yet, right? And we want to differentiate that when a patient says, I want to do this, they're not yet saying I'm going to. So I'm going to is a little bit different. So we want to really support that preparatory change talk so that it ends up moving into what we call mobilizing change talk, which is the cat part of it. And again, I showed you the graph at that beginning, and the graph is about the cat, which is the best predictor of a positive behavioral change, is really that commitment activation. I'm ready to, I will, I did, I'm going to, right? These are things. Okay, so the very last thing I want to say in our final minutes together is that as if there aren't enough acronyms. So we're now in a boat, we've got our oars, we're keeping pace with our spirit of MI, got our binoculars out, and we're looking for our darn cat. What we need to do is keep our ears open, and we need to listen with our ears for the darn cat. And when we hear the darn cat, we need to elaborate the change talk, affirm it, reflect it, and summarize it. Okay. I could do another talk on really how we reflect change talk. And I'm just going to give you instead a summary of that, which is that reflective skill, our ability to reflect what other people are saying to us, does not mean we agree with them, right? So reflection does not mean agreement. So we can reflect our spouses even if we don't agree with them. We can reflect our clients even if we would make different choices. So what reflection does is get them heard. Make sure that they understand that you know fully what they're thinking and feeling and doing and where they're coming from. And it's actually the key skill for expressing empathy. And it also really helps the client explore their ambivalence, because if they have a safe, secure place to explore not changing from, they're going to think about change differently. If they're in a place of feeling pressure to change, they're actually going to look for safety and hunker down and not changing, right? So we want to give them this secure empathy base of understanding where they're at so that they can explore other possibilities. And the way we do that is through reflective listening. What's really different about MI and was struggling for me many years ago at first was that I was taught from other therapeutic kind of styles that you reflect as a question. So you say things like, so it sounds like you might be feeling blah, and your voice goes up at the end, and you raise it up. Whereas if you give a reflection with your voice tone going down at the end as a statement, it turns out that that has a very different feel in the room with your help between that collaborative exchange, that conversation. When you say the reflection as a form of a statement, it's less likely to evoke resistance, and it's more likely to provoke engagement, as it's more a statement of understanding, not a question. So reflective responses build rapport, because when you say, it sounds like you're feeling this, the person thinks, hey, this person is paying attention and they're really trying to understand me. So even if your reflection is wrong, it turns out they tend to aid forward word momentum. So if they say something to you and you say, you feel sad, and they don't really feel sad, they'll say, it's not really quite sad. It's more like blah, blah, blah. So again, there's very strong evidence from the deliberate practice world that even skilled helpers benefit from practicing reflections a lot. Moreover, in the dynamics of language, a question requires a response, right? And asking people about the meaning and questioning distances people from experiencing it. They step back and begin to ask whether they really do or do feel what they should have expressed. And that separates them from their experience, which actually it's just a different process in the room. So the MI reflection is way more about a statement. And I will tell you that there are many, many types of MI reflections. And there are hours that we could spend training on different MI reflections. And we're not going to actually go through that today, but I want to show you one other thing, if I can figure out. Okay, so this would be an example about how you can do a reflection. So we're going to end here. So if the person says, I don't like conflict, how do you reflect? The very first thing that you can do is a simple reflection. And if somebody says, I don't like conflict, you can change the I to you and make it a statement and say it back. So you say, you don't like conflict. And that is the simplest type of reflection. It's pretty much parroting what they say, but that mirror of you don't like conflict has a helpful effect of them saying, you get me and you heard me, and it also helps them go deeper. You can also take a guess at what they say. So for a deeper reflection, you can say any one of a number of things, like it makes you uncomfortable when people disagree. You work hard to resolve differences. You avoid confrontations. You look for ways for people to work together. Anger scares you. So not liking conflict can have lots and lots of different meaning for people. You can take a guess at that. And if you're wrong, they will work with you to help you understand the deeper meaning of what I don't like conflict says. Okay. So that's basically how we reflect. We start with they make an I statement and we change that I to a you, and we can simply just reflect back exactly what they said. You don't like conflict. Or we take a stab at something that's under the iceberg and we say that as a statement, and we see where that goes. Okay, I wanted to show you my last slide, but I'm going to stop sharing this now, I think, because we have 1 minute left. And in the stop sharing, my last slide was a picture that I put together of two people in a boat with binoculars, with a cat out in the water. They have the oars and they have big ears on, listening, to give you that graphic visual image of what all we're trying to pull together to offer MI as an evidence-based way to help people make changes that they're interested in making, but they're ambivalent about and unsure about how to take the next step. And that's it for today. Thank you so much for coming, and I welcome any thoughts or comments in the chat. And I think our next thing is at 3:30, so I'll hang out for a few minutes while we finish up.